So, good afternoon. I'm Keith O'Hall, I'm the President and CEO of Commquest Services, and just want to thank you all for coming here today. We really are appreciative of what Representative West and Director Corcoran have put together to spend a little bit of time in our community today. All of us in the business that we're in are impacted by Medicaid, impacted by managed care. And as Thomas and I have been speaking over the last couple of years, and Maureen in her new role, we think it's important that we as communities have opportunities to share and hear from the folks that are making decisions. But the really cool part about both Director Corcoran and Representative West is they are really, really good listeners. And as I've been at a number of different meetings, what's changing in the field that we're in the behavioral health field, is that as we brought forth those concerns, real change is occurring, guys. And that hasn't always been the case. So without further ado, I'd like to introduce Representative West, and he can tell you kind of what's going on. So thank you all for coming.
Thank you, Keith. Isn't this an awesome building?
Yeah.
This is probably one of the beautifulest halls in our city, and I thank Keith, can't thank him enough for hosting this event. Over the last 2 or 3 years, throughout our community, we've had major health concerns, and we've had major health issues that affected your business, affected your nonprofit organizations, but ultimately affected our community. And when our new director, Maureen, came in, and she came in my office, we had an opportunity to have a really heart-to-heart talk. And one of the things I asked her, I said, are you willing to come to Stark County? Are you willing to come and talk to the citizens of Stark County? And she emphatically said yes, and gave me her cell phone. Right then I knew that she was a person of strength, a person that was not afraid to come out and talk to the people. And I can tell you this clearly, that I look forward to working with her, not as a Republican-Democrat thing, but really looking at the health concerns of our community and trying to affect change in our community. And as we went around the neighborhood and talked to all the different agencies here, we heard issues about behavioral health redesign. I learned something new, a new thing called PBM, Pharmacy Benefit Management Group, a middleman, right? And then we started to work on policies, and many of those things came from each and every one of you. When you come to our office, and Carla, wave your hand back there. Carla takes a lot of your calls, and Carla's my legislative aide, and she takes a lot of those information down. And then we actively pursue and work on every issue that comes through our office. And we are in direct connection with the Department of Medicaid, as well as all the departments across the State House. And let me also say this, and I've got to applaud the governor for his dream team. Social service now is a focus in the state of Ohio. Give that a round of applause. Children is a focus in this administration and this state house. Give that a round of applause. And more importantly, our families. And I think that's the main key, is making certain that our families are intact and that our families are not just survive, but they also thrive. And I think that's what we're looking for today. So today I'm going to introduce, of course, Director Corcoran to come up and say a few words about the state of Medicaid. And then we're most importantly going to answer your questions and your concerns. And we're going to field those. So Carla will have the mic. And just raise your hand, and then she will bring the mic around to you and ask your question, and then we'll fill it. Okay? With that being said, Director.
Thank you, Rep. West. I think the thing that really drew us together is, most of you know, Rep. West has a clinical background himself. And for somebody like me, being a nurse, being able to talk to somebody who I know really understands it at the level of the people that we're trying to serve really makes for a very deep and much more meaningful policy conversation. So we did kind of hit it off immediately. Before I start, I want to just introduce the rest of the team from Medicaid that are here with me. So if you would stand up. So Kevin Walters is our press secretary. Stephen Alexander is with our legislative relations, government relations group. And Marissa Weisel is our deputy for some of the policy initiatives that we're going to be talking about today. So let me just talk to you at a very high level about a few of the major themes from the budget. And then, as Rep. West said, we'd like to just hear from you. Hear what's going on, what you're experiencing. We're beginning now. The budget did pass finally. I began to wonder if it was ever going to pass. Really. But now we're beginning to get ready to move forward. And so any of your ideas or thoughts about how we do some of these things or what kind of ways are going to be most helpful to get input from you, really any of that would be welcome feedback to us. So a couple of the big themes. I say to people, the governor's got 8 kids and he's got 24 grandkids, and he started out as a county prosecutor. And I honestly believe that is part of why, he is so real about the person, the individual person in a community, at the church, woman delivering a baby. And I get these little notes from him all the time, with individual people's names, and could I call and talk to them? And so it's very genuine. It's very genuine, which I really appreciate. But his priority, our priority, is, exactly as Rep. West said, giving an opportunity to every Ohio kid, Recovery Ohio, both in mental health and substance use, as well as, opioid disorder specifically, reforming our child welfare system, and in particular, just bringing a better level of services to Ohioans, particularly through our managed care procurement. So the budget was actually amazingly, all of the policy initiatives that we put in, really across the administration, were maintained. Ours were, in Medicaid, they were all supported and all included, and some additional things. So literally, we've got a list of 118 things that we're sorting out, and are going to be trying to figure out how to make it all happen now in the next, beginning a week ago. So just a few specific things about behavioral health, because I know that's kind of the core interest of our discussion for today. But today is August 1st, as you know, and yesterday the governor released an executive order that implements the emergency rules to bring about a series of rate and credentialing changes associated with the BH redesign. So I'm sure that many of you were probably on the May 29th webinar, or maybe some of you joined us in Columbus. We had a total about 800 people either present or on the phone. It was a pretty amazing degree of interest. And at that time, we went over where everything stood, as well as a series of changes or decisions that we had already made at that point, responding to the behavioral health challenges of BH redesign. And at that time, so there were some changes in there, and by now I'm assuming most of that is kind of all filtered out and folks have got a pretty good understanding of it. But at that time, we also indicated that we would be looking at some of the issues on the fix-it list, as we call it, that got more to the rates. And so that's what was announced, or what the executive order yesterday covered. And so these changes to the rates are in effect as of today. And I'm not going to go through all of those, but glad to, talk a little bit about it if it's helpful. But the most important thing that we want you to understand about that is it is about $50 million. We were able to get it very late in the budget process. And the way that we approached it was to, number one, and most center of mind for us, was understanding that we needed to get some immediate stability into the provider community to the greatest extent we could. And so our decisions were heavily guided by what we could do quickly and what we could do in a targeted enough fashion that we knew it would get to some of the problem areas in particular. So all of the rates that were announced are, increases. There are no decreases or cuts in any other rates. We know that some of the changes we're going to have to come back and tweak or make some changes to going forward, meaning we're just in some ways kind of throwing open the doors on a couple of things and knowing that we're going to have to come back and kind of look at what it is down the road and make some changes to it. But we felt that it was that important to get some immediate relief into the community behavioral health system. So that's just a little bit about our thinking process. There still obviously are other things that are also very important. Some of them, though, would have taken more significant coding changes with the managed care plans or more difficult kind of technical changes with CMS. And so those things we've kind of held off and are continuing to work in those areas as well. So it was kind of an immediate relief sort of thrust. Then, as you know, we're very soon going to have the approval for the SUD waiver, the 1115 waiver. So we're moving forward with that. There'll be a lot more discussion about that. And we have a very aggressive, really, array of initiatives targeted at children's behavioral health. And as some of you know that I've worked with, that's an area of particular passion and concern for us. In that, every day we send about 140 kids out of state because we can't get the kind of behavioral health services that they need. And some of those kids cost $1,800 a day. Now, the money is not my primary concern in saying that. My reason for saying that is we know, because I've dealt with these kids, we know that they are some very, very complex needs, and we need to build up our own capacity here in Ohio to be able to address that. So we're working really closely with Director Chris on all of these initiatives, but particularly with Lori, with Kim Hall in JFS, and with Sarah Latourette in our Family and Children First area to really begin to roll out a more comprehensive array of children's continuum of care. We're in the middle of the procurement. We're getting feedback. We're in the RFI process. We're getting feedback from people. We'll be doing another round of input. We're going to be doing some regional meetings and talking to different groups. We're really making an effort to try to identify some of the consumer and family groups and try to get some targeted input from them. And so we'll be going through the procurement process late this year and early next year. And we've been very clear, we do not have something preconceived in our mind, and conversely, we're not just going to go out and buy the exact same thing we have today. So we're really seriously interested in people's feedback. I got a very lengthy, 7-8 pages from Teresa Gamble yesterday from the Ohio Council that I know many of you are associated with to kind of help begin to get us some specific feedback. So that's a very, very quick sort of overview. And then let's just take questions and we'll get into any other of these areas in more depth that you'd like to talk about. This morning we spent the morning with one of the centering programs. So the whole area of particularly mothers and mothers with substance use disorders and their babies is an area of very significant concern for us, as well as honestly personally for the governor. We have a couple of programs in Ohio, but really the trend, the need is to have a situation where we can treat both the mom and the baby at the same time and not have the mom be in fear that child welfare is going to come and take her baby, or conversely, that mom's not going to get her own substance use disorder taken care of while the baby's being taken care of. So we just this past week announced put out, and we're glad to talk some more about the detail on that. Marissa's been working on that, but that's 47 million, 26 million in infant mortality grants to specific communities in Ohio where we have the highest infant mortality rates. And as you know, I know I've mentioned this in a number of our public discussions, we have among the worst rate of death among infants who are African American babies in this state, and it is a tragedy of unmeasurable proportions. So we are putting significant targeted resources and energy to try to tackle that with communities.
Now let's open it up for some questions. And again, this is your time to ask any questions, especially as it relates to Medicaid. And if there's something we don't know, what we will do is write that down and make sure we get back with you. And I believe everybody signed in at the desk, so we'll have everybody's information. So with that being said, the floor is open. Who's first? Don't be shy.
Hi, my name is Jim Adams. I'm the Health Commissioner at Kansas City Public Health. And I just really wanted to thank the Department of Medicaid for their funding for our infant mortality reduction efforts. As you know, we're one of the 9 Ohio Equity Institute communities, and without that influx of funding, we would not be able to do the strategies and the programming that has made such a difference in infant mortality in Stark County. I would just like to take a second and share with you a couple of these numbers because we think they're pretty amazing. So in the last 2 quarters of this year, our infant mortality rate has dropped from, in 2017, the black infant mortality rate in our community was over 17 deaths per 1,000 live births. And put the white infant mortality rate at that same time was about 8 per 1,000 live births. So there was a considerable inequity in that, and that is a specific thing that we were working on. Our current infant mortality rate, I'm going to say this slow so it'll sink in, the white infant mortality rate in Stark County is 6.0 per 1,000 live births, which you may know is also the Healthy People 2020 goal. But more importantly, the black infant mortality rate in Stark County is 6 per 1,000 live births. So we've achieved. It's amazing. We hope that we have hundreds of quarters like that. So, we're very excited about the work that's been done in the community. This is work that was, the health department may kind of, foster that a little bit, but the work is really done by the community and by the collaborations that we built largely through some of the funding that the Department of Medicaid has provided. We're very appreciative of that. We're looking forward to the next round of funding. We've seen success, and we're not going to take our foot off the gas. We've seen successes, and we're going to keep going. So I just wanted to thank you so much for that support. 6.
That is the best news I've heard in a long time. That is amazing. That is really amazing.
We think so. We think so too.
Yeah, absolutely. That's very impressive.
Hey, good afternoon. I'm Steve Fettman, and I'm a pharmacist here in Canton. And, well, thank you, Thomas. We appreciate all you've done for us as well. The one question I have is, what is your vision to create a better and more sustainable pharmacy program under a single PBM model? And do you feel that the PBM that's going to be chosen by the state is going to have too much power as we've seen in the past?
This, for those of you that maybe weren't following this part of the budget as closely, the pharmacy issues and the single pharmacy benefit manager issue really was a pivotal topic, a key policy concern from the very beginning of the budget and was till the very end of the budget, all the way through. And, honestly, while it didn't end up the way that the executive had submitted it, I really appreciated the level of dialogue that occurred through the process. I don't think that all the policymakers who needed to understand the issues associated with medications and pharmacy services really, had as much of a grasp as they did by the time we were finished with the budget. So there really are about 6 or 8 key things in the budget related to pharmacy and the single PBM. We'll have some of our policy updates ready to post pretty soon, and we'll go over these. But the most important thing to take away from the conversation is it is not one thing. I mean, there are 6 or 8 things that are in the budget. There's also at least that many, if not more, key changes that we made in the managed care plans contracts with us about pharmacy and medication. So this is something that we've really been tackling in as comprehensive a fashion as we can. So I'm going to focus on your question, but I also don't, I want folks to know there's also, a couple of things in there like a cross-department pharmacy advisory committee. There's also some initiatives that are very specifically targeted at the price of medications, and so that's really more of concern to the manufacturers. So, we're taking a very comprehensive approach to this. And recognizing, as I kept saying to the legislators through the process, we know this is a key issue for Americans across the United States, right? It's not just Medicaid, it's not just Ohio. So specific then to your question, there's a couple of key elements. We are moving forward with a single preferred drug list, or a unified preferred drug list. And that'll be soon. So we're not waiting on that. And what's important about that is, what we know for providers is that to deal with 6 different formularies, and worse yet, for a mother who may get to the pharmacy at 4:30 on Friday and not have the right, generic or brand name of the ADHD medication on there, even though they're all exactly the same from a chemical point of view, means mom's not going to be able to take the medicine home, right? So, unified preferred drug list is being developed now, and then we have, the governor agrees that we will go forward with a single PBM. That was the will of the legislature in the budget process, and I think what I've been saying to folks is, look, it wasn't what we suggested, but I think we all recognize that there is a problem, and so we're going to try another way to tackle it. I don't know whether it is the best for Ohio in the long run, but there are other states that have done this. It is doable, and so I am looking forward to the work going forward to tackle this. I do believe that it will bring the things that the General Assembly wanted brought to bear, and that is more transparency, more direct control by the state. So there's a lot to that design work that we are just really beginning. But I would also say to you that in the course of those conversations, there's a couple things in particular about pharmacists and pharmacy services that I think are important to particularly all of our behavioral health considerations, as well as more generally. And that is, I've been pretty consistent in saying that in terms of access to medications for people on Medicaid, we cannot maintain adequate access if we're only working with the big box stores. Can't do it. So, in the course of the conversations, we recognize that there has to be some targeted changes that will enable us to put a better level of more sustainable payments and assurance to individual, independent, and small chain pharmacies, particularly in areas where we have more difficulty with access. Now, just like what we're experiencing more broadly in behavioral health, and I don't need to tell you as a pharmacist this, clearly there is a consolidation occurring in the pharmacy industry more broadly. I can't turn that entire dynamic around, but we need to maintain access, and I don't want to be exacerbating a change in an industry that's going to result in people having less access. So there is some money identified in the budget that's specific to dispensing fees, and so we will be looking at the mandate in the legislature, and a bunch of the detail was vetoed. But it was just detail that was vetoed so that we could be sure we could get to the intent. So we are doing what the legislature indicated, but we took out a bunch of the detail where there was formulas and other things that honestly didn't quite add up right. So we will be developing a formula where we can get at pharmacies, particularly with a higher concentration of Medicaid individuals who we need to be able to assure access for. And so that is not how our system is set up today, and that is one of the commitments that we've made. The other thing that is really important is that pharmacists, as we all know, have a lot of training. As I mentioned, I'm a nurse. Give me a couple of good pharmacists any day of the week in our department if there's questions or problems related to medications and side effects and interactions. And so we are also looking at how to add certain clinical billable services for pharmacists so that they can assist with education, medication monitoring, some of those things, in addition to just dispensing. And what we do now currently have is a little bit of administration of particularly IM and other kinds of injectable medications. So.
Let me also just add to that. And I think one of the big things that happened in the budget was the passing of House Bill 63, and that was to eliminate clawback clause and to bring more transparency. And that was our bill that myself and Representative Lips brought forward last year, House Bill 479, and that was maintained in the budget. So now we're looking at individuals and everyday people can actually talk to their pharmacist and get real information without having to worry about them holding their tongue because of some contractual obligation. This way, the person can really trust their pharmacist and the information that is coming from that pharmacist. I don't know about you, but when I go to the pharmacy and I'm sick, that's at my most vulnerable time. And I trust that pharmacist is going to tell me that this is the drug and this is the cost of the drug. And matter of fact, there's this extra money, and if you don't use your insurance card, then why did it be cheaper? Well, we eliminated all that through the transparency process and through the elimination of callbacks. Pharmacists, independent pharmacists like Davies Drugs, like the Medicine Shop, like all of the major pharmacies that you like here in Canton. I think we got the best. I'm just saying. But when that came up, it literally came from people here. That's how I got involved in it. From my pharmacists here, from my students here, brought this issue, and I think that's why it's so valuable and important for you guys to continue to tell us about the process as we move forward through the Medicaid process, and as they bring this PBM issue to bear. By all means, you guys bring that to us. We'll appreciate you for that. Questions? Don't be shy.
Good afternoon, Director Corcoran. I would just say on behalf of the behavioral health providers in the community, there's been more movement with BH redesign since January than there probably had been in the last 18 months. So we do want to thank you for your willingness to do that. I do think a related question. So as we've had one of our hospitals who have eliminated their psychiatric unit due to Medicaid reimbursement rates, and as we brought up mobile response in light of the suicide contagion we had with youth, what's becoming apparent is oftentimes there's a significant amount of dollars that need to be reimbursed from the local community to support those initiatives. And while we know Medicaid can't pay for it all, if the client has Medicaid, can you just talk a little bit about your philosophy and maybe your willingness to look at that, to be able to kind of branch off? And so I just pulled some numbers today. I mean, as a local community, we're investing about $1.5 million into those crisis services. And oftentimes, again, it's for folks that do have Medicaid. It's just certain things can't be billed and some of the taxonomy. And so I just wanted to kind of get your response. And then also on the end about possibly looking at the reimbursement rate for private hospitals and kind of inpatient psychiatric units. Thank you.
So on the crisis component, and you know we sat in the same room for 2.5 years on this, but a decision was made with the BH redesign, as many of you know, where there was only really the crisis psychotherapy code was the only real vehicle that was maintained in the BH redesign. And at that time, a commitment was made, which we're glad for, and we're continuing to carry forth on that commitment, that we knew that it was going to have a pretty significant impact on community crisis capacity. So in the rates that were announced or effective today, there are a number of those specific codes, I know you know this, that were specifically targeted to open up the crisis. So for example, today, if one of our agencies goes into a hospital emergency room, because the service is provided to a person who is in the emergency room, the hospital is supposed to pay you for it, okay? Part of their bundled payment. Well, how realistic is that, right? So, we know we're going to have to work on that in the long run, but basically what we've done is to say, no, if a service is provided in an emergency room by a community behavioral health provider and a whole variety of additional modifiers and codes were opened up to enable various emergency and crisis services in the community as well as in the emergency room. Also, increasing the nurse APRN rates to equal the physician rates. We heard that quite a bit from the community as well as from family members with concerns about medications and emergency medications. So there are a number of things in today's rate changes that are very specifically because of the crisis concern. And then I would just say to you that, Lori and I, Director Chris and I have had several conversations about crisis, and we are both very much committed to figuring out how we can, I'll call it sort of braid together the resources that are necessary so that communities can have the kind of crisis capacity they need. So not just looking at it as, well, I'm Medicaid and I can only pay for Stephen and Marissa, and I'm not going to pay for Kevin because he's not on Medicaid. So we have some hard work to do there. That's one of those kind of one of those things we couldn't fully fix today, but is high on our list of work that we're going to be doing to try to bring as much of the resources together as we can. Say a little bit more about what's the hospital inpatient problem that you're seeing up here.
So I think what we're being told is, and I think when you look at the numbers, the reimbursement rate of what they can bill for Medicaid to be able to operate the unit, but it's not covering the cost. And so they indicated that they were losing a significant amount of resources. And I do think anecdotally, when I sit in other meetings, I hear the same thing from other hospitals, that there's really not an incentive to possibly provide that service because of the reimbursement rate that's currently being provided.
So that's helpful. I just wanted to check whether there was something kind of peculiar or unique. So yeah, we are beginning the rebasing process for the hospitals, and that, obviously the behavioral health stuff, behavioral health and the kids' work is really the reason I took this job. So, for me, the reason I'm here is because this is what I want to be doing. Now I have to do all those other things too, but this is why I'm here. So we are going to be looking at all of the hospital and FQHC related issues with behavioral health. Not sure what exactly the right answer is yet, but and we also are working very closely with the hospital association as well as the community behavioral health associations.
Hi, good afternoon. My name is Susan Sigmund and I'm with Direction Home Area Agency on Aging. And kudos to both Representative West and Director Corcoran for your time, certainly, but most of all, your leadership and your dedication to the work that we're all charged to do. And if I can, I certainly understand the focus on kids, infant mortality, behavioral health. I would be remiss if I did not put on the table here, what may I ask what the administration's vision is as it relates to older adults? Yes, my question is a little bit about my care, but probably even broader than that. If you could speak to that, please.
Absolutely. I actually spent Monday night rereading our CMS Home and Community-Based Services waiver transition plan that we were getting ready to send back to CMS. So, that is an area that, more so directly with the DD field, but we also did some work with the assisted living services in our prior lives. So an area that we're not unfamiliar with. But so there's a couple of key takeaways from the budget in this area. There were several areas that relate to, particularly to long-term services and supports in the community, that were vetoed. And this is actually kind of a broader theme for people just to be aware of. And several of them were in the long-term service and support area, as you know. We were very glad that particularly the senior advocacy was able to get rate increases for passport, assisted living. There was a bunch of meal, and this was the food budget, we called it, in the department, with meals, snacks, and food pharmacies, so everything seemed to be about food in this budget. But all the specific rates were vetoed, but we are doing all of them, okay? So the principle that the governor asked us to look at the budget with was, we don't believe as a matter of policy that it's a good thing to put in law that we'll pay $5.63 for a certain type of meal, particularly because we knew in that case that given the appropriations, we would have had to cut, for example, kosher meals. Okay, so that's the kind of stuff that can get kind of out of whack if you start putting rates in statute. So the appropriations were maintained, the intent is maintained. We've been talking with Director McElroy, who I like very much. And so we're going to be moving forward with those. We'll be talking with the area agency. I got 3 texts from Lark today. We'll be talking with the area agency folks about how to get some input. We're also working, as you probably know, on realigning all of the waivers to make sure that there is more similarity across them, because from a workforce point of view, to have very similar waivers that have different requirements is really goofy. So we are continuing that effort or that work. We were able to maintain my care, which was no small feat, but I think because we were able to get that off the table so early, I think some folks kind of lost sight of it. But there still is work we need to do. There are concerns from providers and from the nursing facilities about some of the managed care issues. And for those of us in the room from behavioral health, the concerns that some of the MyCare folks are having are actually identical to the concerns that we've been dealing with behavioral health. So we've committed to work on some of those things. So I guess sort of in general, I'm looking forward to having some more in-depth conversation about where we are going with the overall home and community-based services capacity in our state. And I think that the transition plan gives us a perfect vehicle for those conversations. I'm also particularly interested, and we've been talking to some researchers about looking at those care coordination models or examples within MyCare where it's actually been delegated to the area agency to see what are you one of those? Because I suspect that there is a measurable difference there. So that's just a few of the things. And I do appreciate that with all the focus on behavioral health and kids, I think some of our partners in the aging world have felt a little neglected. But it's not for lack of I got probably 10 things on our list of 118 that we've got to be working on in that field. So thanks.
he's IDD, he's acuity level C, and he resides here in the community of Stark County on an HCBS waiver, an Iowa waiver. You talked about realignment of waivers. You know, DD currently has 3 waivers, all right? Are you looking at those waivers also to be reevaluated and streamlined?
We're not touching the DD waivers.
Okay. Well, that's comforting to know that, because there's such disparity between individual to individual in DD that, you know, one size fits all just doesn't work.
No, that's right. And we all could take some lessons from the DD community. What I was referring to is in terms of our nursing facility level of care waivers, we have similar services that are defined differently, and they have different criteria and requirements. So that's what we're talking about in terms of alignment within the, not the DD waivers, but the other waivers.
Okay. Thank you.
Sure. And we are working, I don't know if you know, I came out of the DD field. I was with Opera for 10 years. So Jeff Davis and I are very good friends, and we're having some great discussions about multi-system kids who may have a little more, you know, may come from either more of a DD perspective or background, as well as kids who may be coming, if you will, a little more from a behavioral health point of view, and how we marry together those services and those strategies so that we don't have families falling through the cracks. We have quite a large number, actually, of kids today who are literally falling through the cracks of our waivers and the DD waivers, and so we try to figure out how to kind of close those gaps.
From Tuscarawas County, representing the southern part, so I'm kind of crashing your Stark County party, but thanks for Commquest for inviting me. Right now, we're working with, I'm in charge of a 5-county hub model, so I'm not sure if you're aware of this. Right now, we're only contracting, and I was curious to see if the county health department was working with the Pathways hub model, that's where you had seen your drop with sorry, I've never had to speak in a meeting like this. I'm like almost shaking. If that's why you would have. All right, good. So they're shaking their heads. So yes, are you aware of the hub model, the community pathways? So my question is, do you have a vision where, as of right now, the only billing codes and the only, you know, we send out community health workers into this 5 counties, so Carroll, Coshocton, Tuscarawas, Guernsey, and Muskingum, and probably, you know, all of those counties don't equal this population, but the access to care is a big struggle for us. And using that model, we're able to get into the home. We see somebody in the behavioral health, and they will send us a referral, and then we get in the home, and then we see, here's the child here that needs to be connected to Head Start. This one needs to be here. Here's a mom with helping with caregiving with the undiagnosed. So I'm curious. We are looking to expand that, not just for the infant mortality, but into chronic disease, into the elder population. And I'm curious to see if you see that and see a vision where you're going to open this up to straight Medicaid eventually, where we could do billing codes with this. They're shaking their heads. Yes? Go ahead.
Well, sure.
Okay. But that's just where, you know, it has made a huge difference in our small town community where we don't have, you can't get onto a bus to get your medication. You have to use those kind of things. So I'm just curious if you see that opening up for chronic disease and other population. Thank you.
So, Marissa, why don't you come on? So I think this is of interest broadly to communities. The governor's committed, as you know, to a 3 times expansion of the amount of home visiting in Ohio. Marissa's been spending about 28 hours of every 24-hour day working on this, so I wanted to give you a little bit of an overview, and then I'll speak more directly to your question.
Thank you.
Hello. So the governor has directed us across the administration to triple the number of home visits, and he created a home visiting advisory committee very quickly after coming into office. I think maybe he signed an executive order about that the night that he took the oath of office. And that advisory committee examined various models of home visiting and ways that we can specifically help pregnant women and young kids with home visits. The models that were studied were some of those that were funded by the Department of Health today in the Healthy Growth space, those that are funded by the Department of Developmental Disabilities in the early intervention space, and then we also looked at the models that are funded in part through Medicaid funding in the 9 infant mortality hotspot counties, as well as through the Commission on Minority Health through their hub grants. So we took an expansive view from the start, and we at Medicaid continue to take that expansive view as we look at how we will spend the $47 million we were allocated through the budget to develop our own maternal and infant support program that will include home visiting. So I can say that in the infant mortality space, so for women who might become pregnant, are pregnant, and in the postpartum space until the baby's about a year old, Medicaid is looking at models that will involve community health workers, peers, maybe things like doulas, as well as kind of more traditional evidence-based home visiting for the service that we bring up. We continue to work with the Commission on Infant Mortality, or the Commission on Minority Health, to look at the hub model in other spaces. Our Medicaid managed care plans, all 5 of them, contract with hubs in the 5 infant mortality hotspot regions of the state. And they continue to have the choice to contract with hubs in other areas around services that are beyond infant mortality, maternal and infant health. So that's kind of the big picture. I'll let you take the next question.
Okay, so I guess just correct me if I'm wrong here. So across the cabinet and across the various departments that have, served some of these groups of individuals and such, we're trying to kind of braid together all the strategies. So, the health department strategy is a little different than our strategy, but they're not being done in isolation from each other. They're being done with kind of different target objectives in mind. And I would not be being honest if I didn't say to you that we are really trying to be laser focused on infant mortality, and particularly African American babies. However, having said that, I do want to just kind of underscore that a key issue in any managed care design is this whole issue of who coordinates what for whom. So this is of interest and concern really across the board, whether it's pharmacists or behavioral health providers or in this area. And so first, I would encourage you to give us some feedback as part of this procurement process. We are laser focused on what the care coordination models and options should be. Okay? I'm not going to kid you though. Care coordination from a Medicaid point of view tends to be a place where CMS gets very picky because they don't want to be paying 3 times for assisting us.
Right. Well, my follow-up question would be then, since we're so rural, we're not in that 9, we have applied for, we're going for certification, we've applied for the minority grant, but so they have the option right now, so we don't have all the contracting in our rural area because they have the option to not contract with us. So that's where I guess I would look to, my input would be, can we, instead of just saying we have 9, let's look at the state and say, we got rural Appalachian women who also would fall in that category. So I guess that's one of my thoughts.
Thank you. That's a really good point. So in the latest update to our managed care contract that we have with the plan, that started July 1, we included some language around requiring the plans to contract with all certified hubs. So once you're through the certification process, they've got to consider you something that they've got to have in your network.
But it's backwards because we're going to certification and we can't get certified until we have the contract. So they won't certify us until we have our own contracts with CareSource and United. We have to have them before certification. I just on the phone with Dr. Redding, so that's where I guess I'm like, wait, what? You know what I'm saying?
Yeah.
It's a catch-22. Which one do we do for? Where to go
I
first?
saw some email traffic from Dr. Redding a couple of weeks ago and couldn't figure out what it was about, so this might be it. I would love to talk to you about this offline.
Yes, let's do it.
We'll see if we can ratio.
Yes, thank you. I would love
Yeah,
that.
absolutely.
And so would all of my 5 county people. So thank you, Stark County, for
I just wanted to point out we are also following doing reimbursement for chronic disease management using our pathways also.
I think this is also a time for me to jump in here real quick. You know, and we talked a lot about infant mortality, and I'm so thankful for all the infant mortality people in the room. Just raise your hand real quick, all the infant mortality. Okay, very good, very good. Keep working hard. But, you know, it's interesting because I keep hearing, you know, again, the focus, the laser focus on, of course, the mom and the babies. But we're losing fact that dads count too. And dads contribute to, you know, that whole picture. We got to start looking at that in every silo, in every department, and making certain that dad's involved, because he reduces the stress. And I know that the Canton Urban League here is working heavily on research around toxic stress and how you reduce that. That's something that we got to make certain that we keep in the forefront, and making certain that the family unit also includes that dad. So we need to make sure that we focus on that, okay? Any other questions? Yes, ma'am. And don't be shy, because she's here to listen to you. And she's going to take this back and hopefully fix the problems that you may be experiencing. And we've got a few more minutes, so we want to make sure that we get as many of them as possible.
Yeah, and I just want to underscore that. I know people probably haven't entirely sorted out what the changes from yesterday mean, but, you know, please don't let that impair your ability to just tell me what you're experiencing, what you're thinking, what's going on, even if we've already started fixing it.
Hi, I'm Kelly Johnson. I'm the Executive Director for Access Health Stark County, and we are involved with both Thrive and the Infant Mortality Project, but we are also, and have been since 2008, a care coordinating agency for people who are at an underinsured, under-resourced, focusing on chronic disease and primary care. So very interested to see them Medicaid expanding the payments for chronic disease. But to build on what she said previously, would also encourage them to stop cutting the rates, because when CHWs were first introduced as an option for improving care, the Medicaid director at that time was very insistent that the pay for these CHWs be enough to get them off of Medicaid, and it is not. And it's less now than it was 2 years ago. So if you can find it in the budget to boost the pay for CHWs and the reimbursement rates, that would be wonderful.
And this is, you're talking about the rates that are paid by the managed care plans? Yes. Okay. I hear you. And I'd love to hear about some things that aren't just rate related.
First of all, thank you for coming. So one of the challenges we have in behavioral health, one of the challenges we seem to have in behavioral health and dealing with the managed care plans is it seems like we're in this constant evolution of change, not just with one plan, but with multiple plans changing. And my understanding from all of the work groups that I was part of, we were supposed to be in this status quo where everybody did things the same way, and some of it's configuration and that. But more and more what's happening, Director, is that, for example, today we've got a request for 43 client records for 1 year from a managed care plan. That requires a lot of time and energy that ultimately then erodes some of the ability to do some other things that we want. So I think there's two things. One, the cost of doing business continues to go up. And what I liked, what I heard you say is that between yourself and Director Chris, looking for ways to break dollars so that we're not just reimbursed on an actual unit, but there's also some dollars that may or may not be available to kind of help offset some of that, just the general cost of doing business. And I think you heard it when you came and talked to the provider, the executive directors and that. But just some sort of consistency from Buckeye at a care source so that Val doesn't send me emails every morning and say, hey, today care source didn't take this, but Buckeye did. that's just kind of, so what's the best way that, one, we can convey that information, and so that in re-procurement, we have a better chance to succeed than what some people may think we have now? Thank you.
So there's a couple different parts to that. Number one, and I know you know this gives me some of our other conversations, but they're across providers, behavioral health and not as well. There is concern about the amount of complexity from one plan to the next. And some of this, we know, the change in the coding and, the ICD-10 and some of that stuff is just part of overall healthcare evolution that we in the behavioral health world had to just, accept and move forward with. But where it is creating differences that do not add value, that is one key area that we are looking at. So if everyone hasn't heard, we've already committed and have started procuring to take credentialing out of each plan, so that the credentialing will no longer be done by each plan individually, but it'll be done once at the state level. It's huge. It is huge. Yeah, usually people clap when I tell them. But it's also a good example, and we're not stopping there. We're looking at some other areas. I mean, ultimately, my goal would be, there are some things that managed care can do that we cannot do with fee-for-service. And so how do we get the emphasis, their innovation, the emphasis, the flexibility they have, how do we get that maximized and get some of these other duplicative administrative kind of processes eliminated? Now, back to the PBM and this unified PDL for a second, that will create a significant streamlining for providers, prescribers, as well as family members. We'll be using all the same prior authorization requirements, so that will help also.
Hi, how are you? It's good to see you again. Just a quick question. First of all, thank you for the rate increases. Those were greatly appreciated from an agency point of view. So I'm going to ask you to make an educated guess. So what kind of delay do you think from the managed care companies to implement those changes? Are they ready for it? Because again, we're still seeing some delays from particular MCOs in payment. So we're just concerned, were they ready for this? Or so just kind of your 2 cents from that.
So one thing generally to your question, and I realize everybody may not be paying attention to all this level of detail, but we've had, since Lori and I came in, we have been meeting every 2 weeks with a stakeholder group of behavioral health constituents, all the managed care plans, all the associations, NAMI, consumers, and in painstaking detail, going through our dashboards about where we are with claims payment, where we are with delays, what the glide path looks like. I mean, painstaking detail. We agreed at the last meeting of that group that we would pivot to now do 2 things instead of 1. And so we will continue a work group that will be on a regular basis continuing to talk with outside stakeholders about where we're having claims delays and problems. And what I think is important just to say again is we are not taking a hands-off approach to the managed care plans. So unlike prior administrations, we've been very roll up our sleeves, go in, look at their IT systems. We have more than 25 staff. We're working with individual providers across the state to figure out what their problems are, how we get them. So this is not a hands-off kind of approach. Okay, very hands-on, very right down in all the coding and IT detail. On this issue of August 1, I am cautiously optimistic. Because I have actually a couple staff that I may have to medicate from PTSD if we don't do it right on August 1. But no, the plans, let's just say it's been made crystal clear to the plans that this must work. And so they got the codes, the citations and things from us more than a month ago, and we told them to be ready. And we just met with them yesterday, with several of them yesterday, and reiterated we want it ready to go now.
Hello, I am Elizabeth. My husband and I own Nighttime Pharmacy here in Canton,
As well as two pharmacies in Central Ohio, one of which is very rural, and our pharmacy here in Canton is a very high Medicaid population. So thank you so much for really identifying the value that community and independent pharmacies bring. My question is, we're currently providing so many wraparound services to our patients, packaging, free delivery, all these services to make sure they're staying compliant, adherent, and healthy, that some of the other pharmacies are not doing. So is there any goal or plan to develop some kind of task force of independent and community pharmacies to work with the Medicaid department and kind of figuring out those clinical services that might be reimbursed, or just to see in general what we're doing as independent pharmacies for our patients?
Yeah, that's a good suggestion. Let me take that back. And I would also say, we also yesterday got a long letter of a couple pages from the Pharmacy Association, Pharmacists Association, with feedback on the managed care procurement. So this is good timing. It's perfect time to be having this conversation about these other services. We had hoped in the budget discussions, we had hoped to get a little further with more of a value-based strategy for pharmacy services, and couldn't quite get there, but we're continuing to work in that direction nonetheless. So
Perfect, thank you. I know we as owners, there's 3 of us here today, would be very happy to participate in any kind of task force, and just letting you know, we're so proud of independent and community pharmacies. We want to let everyone know what we're doing for our patients, because we think it's really great.
And that's exactly the kind, when we say value-based, that's exactly the kind of thing we're talking about is all the services that you mentioned, which are not readily available by all pharmacies.
Okay, thank you.
Director, I got a quick question, and I don't know if there's any of the dental community here, but I heard from the dentist that a lot of times they don't accept Medicaid because of the bureaucracy, the paperwork, and all the hoops they got to jump. Is there some type of vision to try to erode some of that paperwork so that people will accept Medicaid?
Yeah, that's a good question. We haven't drilled into that yet, to be honest with you. However, I would say that in my initial review of the feedback we're getting, dental is one of the top areas of feedback. Dental behavioral health is one of the top areas. And as you know, the access across Ohio to dental services for people with Medicaid is very poor.
Any other questions?
My name is Andrew Allen. I'm the Director of Adolescent Residential Services here for Commquest. And one of the things that I don't know is just the feedback for us for adolescent is just how complex that we're seeing the cases now. One of the things I think is a misnomer is addiction is very simple for adolescents, but we're seeing more and more complex trauma. Almost all of my kids now have co-occurring mental health disorders, and so I was just curious because you had mentioned specifically, and this is not the first time I've heard it talking about youth. For adolescents or youth that have substance use disorders, what kind of initiatives, what are we looking for here in the upcoming with our governor now?
Let me talk for just a little bit about residential, and then maybe Marissa can add other things for more the community service side of things. We are going to need and want to have some pretty substantial conversation about all of the residential services for kids. And as you know, with the federal Family First law that passed, the child welfare system is going to be undergoing one of the most significant changes in financing in decades. Now that will have a dramatic impact on us in Medicaid and Medicaid financing, and on providers like you and providers who are also certified by JFS, OMAS, as well as DODD in some cases.
So that is one of the things that we're really focused on with the Family First work, is how to bring together a group of, particularly bring together a group of the children's residential and more intensive services, so that we can look across all of those departments and initiatives and what we need to have for kids. And there's no question, I mean, part of the reason why we have 140 kids going out of state every day is because we are getting some really, really complex kids. And so we not only need to enable kids to be in the community or be with kin when they can, or to be in his home-like environment when they can, but a residential component that has the kind of clinical services and attention is clearly absolutely necessary for the long term as well. So we're really interested in working on some of that kind of the residential component of it. Do you want to add a little more from the community side?
Thank you. So most of you know that when the behavioral health redesign package of services were created, nearly all of them were created agnostic to age. So the services for substance use disorder, residential, it's a service. It's the same thing for kids, and you get the same rate for kids and adult. We've got the same requirements, and we know that there aren't very many of you out there doing substance use residential treatment for adolescents. So I think it would be worth our time to take a look at the couple of you who are doing that. You have, is it a handful?
I think we have 4 or 5 in the state.
Yeah, there aren't very many of you, so I'm really glad you brought this up. That's something I'd really like to dig into with you to see, how is this different? What should we be thinking about? As the director mentioned, we're really looking across systems at what our continuum of services are for kids, knowing that there's more and more complexity and trauma, particularly as more and more kids are interacting with the child protection system and are interacting with other kids who have their own trauma and are being re-traumatized all the time. Some of the community services that we're thinking about are, a better sense of respite for kids with behavioral health needs, so that their parents can really get a break when that looks a little bit more like the DD system's respite. We know that often parents just need to be away from their kids for 24 hours, and the respite service that we've developed today for behavioral health doesn't meet that need. So we're really trying to think about the unique needs of kids and our behavioral health service package, and we'll have lots of opportunity for stakeholder input into that.
We also mentioned that in House Bill 12, it's a priority bill, we're designing the Children's Behavioral Health Prevention Network to do a lot of the children's behavioral health issues and really focus in on prevention so that we can tackle some of those things. And one of the things that being a ranking member of Health and Human Services, I've heard these stories time and time again, even with multi-system youth, about parents having to give up custody in order to get their kids treatment. So that's something that we're also working on at state level. So just know that help is on the way. Ms. Spencer, my partner.
Brings me to a great question, and it's going to be on your number 200, Director Cochran, which I am so excited about. You're Patty Frenzer, Director of the Best Practices in Schizophrenia Treatment, and we just finished, actually, why I was late, coming from the System of Care Echo that we do in partnership with Rick Scheffler's team, and the pharmacist on it has opened my eyes to what we can do when we see the number of meds our kids are on for multiple reasons. The pharmacist starts really putting the pieces together. But here's my dream. You have lots of kids that have parents, because we have more insurance today, private insurance, need to get off their private insurance to access the services of Medicaid. We will never decrease cost of Medicaid until we start diving into the private insurance system to cover the same things that are public service. And I watch that with first episode psychosis every day with the treatment we do, because we identify them when they're young, still on parents' insurance, but the only thing private insurance will pay for is inpatient, which is not evidence-based care. So until we start down that road, we're going to always be moving into why parents need to release custody. So, dream.
Well, if I can just mention, one of the earliest conversations that I was part of with the governor was around the Recovery Ohio report, and there are specific recommendations in there about parity.
And honestly, I wouldn't have faulted the governor at all from kind of taking a half a step back from it, and he did not. So, exactly your point about parity. So we are pushing forward in Medicaid. This other conversation I'm mentioning was not about Medicaid, it was with the Department of Insurance, so we're with you.
Thank you. And I'm going to actually have to skip out of here, and I've got another, the Ohio Promise tour, which is a framework, a legislative framework that we actually are unveiling all across the state, and we are hosting that down at City Hall, and that's at 3:30. So I'm going to rush from here to there and get that going. So you're welcome to come down there as well. If there's any last pressing question for the director, there you go, Jan.
Hi, my name's Jan Doherty, and I'm with the Summit County Board of Developmental Disabilities. And I was wondering if you could speak to the electronic visit verification with our folks that are now required to have their services tracked in the community on where they get picked up, where they go, where they receive services. There's a lot of angst going on in the systems from families feeling like the GPS is tracking them and that they're going to lose services with their independent providers because the providers do not want to be tracked as well. If you could speak to that, thank you.
So this is a tough one. This is another federal law that requires this electronic verification by in-home workers for services to those that are elderly as well as those that are developmentally disabled. When we first came in the end of January, Jeff Davis and I sat down, really hit the pause button here because we were about to drive off a cliff in my estimation. So we have slowed the whole thing down. We are taking a different, there's nothing in the last week or two that's changed about this. I'm just kind of saying what's happened over the last 4 or 5 months is that we've taken more of an educate up front and not turn on the edits for a while until we have some greater level of comfort that the providers are going to have a level of claims payment that mirrors their current payment. We learned that lesson the hard way, didn't we, in the behavioral health field? So we've taken a much more conservative approach to it. We are approaching some of the federal deadlines, and we are being very deliberate about looking at our own readiness, looking at those deadlines, trying to make some more decisions about how hard to push, when to push, that kind of thing. Now, I will say to you, now I wouldn't have written this federal law, let's be clear, but there are certainly circumstances where individuals with developmental disabilities and seniors are being abused or not receiving services that their providers are identifying that they're receiving. And I am not criticizing all providers by any stretch of the imagination. But the fact is that while there's a lot about the electronic visit verification that we don't like, the fact is it will require a level of accountability in the system that will have a positive effect for the health and safety of seniors and people with developmental disabilities. And so we are moving forward as we're required to do, but we're also trying to be very cautious about it and paying attention to when people are ready to go forward. So it's not a very satisfactory answer, but just understand we're watching it closely. We don't have a choice. We're getting to the point where we may be, not yet, but by the end of the year we'll be in a situation where we'll be looking at the possibility of federal penalties and things like that. So we need to stay on track, but we are trying to be very deliberate about it.
Thank you all. Thank you so much for your questions. Thank you so much for your attendance. I know that today is game day for the Pro Football Hall of Fame. I know many of you guys got tickets. And while you're here and while you're downtown, stop at some of the restaurants, stop at some of the entertainment venues, and enjoy the festivities downtown because there's nothing like downtown Canton. And thanks again. Thank you so much, Director, for coming. We really do appreciate you, and we'll be talking in the future. And of course, I've been appointed to the Joint Medicaid Oversight Committee. As soon as we get a director, I think we'll start meeting, right? And hopefully we can also iron out some of these other issues that are facing our community. So again, thank you, and let's give her a round of applause. And again, let me thank Keith. Can't thank you enough for hosting us, and we really appreciate you and your facility and all the service you provide countywide. So again, thank you.
Thank you, guys.